As nurses, we all have our way of doing things. We've developed care routines over time based on what we were taught, but how often are we questioning these habits that we've developed? Evidence actually challenges those habits every time. When we allow the evidence to lead, we move from what feels right to what is actually right, and that's where the true value is created. Today, we're talking about the power of evidence-based practice and how it helps nurses lead meaningful and measurable change across our healthcare systems. Welcome back to this episode of Healthcare Disrupted. Using evidence to standardize care doesn't limit us. It actually frees us to innovate. But more on that later. In this episode, we're going to unpack how evidence-based practice helps nurses at every single level make decisions that add value, improve our outcomes, and strengthen our professional voice. Joining me today is Dr. Chris Baker, our Regional Director of Nursing Excellence, who practices in our Wisconsin region. She is also a clinical nurse specialist and a champion for evidence-based practice across our entire organization. So, Chris, welcome. Thank you for being here. And will you start off by just telling the audience a little bit about yourself, your career, and your interest in evidence-based practice?
Amy, thank you for having me here. I love talking about evidence-based practice. So I've been an evidence geek for a long time. My mother used to say it started when 5-year-old me came home from kindergarten playground and asked her if Santa Claus was real. And she said, well, of course Santa Claus is real. And I asked her, do you have any proof? And she just said, don't tell your brother and sister. So evidence has always been important to me. That said, I started my professional nursing career in the emergency department at St. Mary's Madison. And I love the patients, I love the pace, but the best part was working with a really closely knit interprofessional team to get the best outcomes for our patients. At about that time, St. Mary's Madison was developing their professional governance model, and I joined the steering team and got really excited about system design, about evidence and process improvement. That led me to graduate school for a clinical nurse specialist, then rapidly got involved in a PhD program. I thought I'd go into academia, but I realized very quickly that my best opportunity to use evidence to improve outcomes and value for our patients was going to be in the acute care environment. So that led me to my current role.
And we often think about PhD prepared nurses in the academic environment, but it's really important, as you're pointing out, in our practice environment, and really thinking about how do we use evidence and how do we improve our outcomes. And we're so thankful to have you here in the organization and really leading this work. So let's start out with some clarity. So we use a couple of terms in the healthcare space. You will often hear us nurses talk about evidence-based practice. You will often hear our counterparts, our physician colleagues, talk about things like evidence-based medicine. So can you tell me a little bit about what the two terms mean? What are the similarities and what are the differences? And what is the point? What are we really trying to accomplish?
Okay. That's a great question. So if we talk about evidence-based medicine, you can go back to the 1890s and, find some nascent ideas about evidence-based medicine. But it was really in 1996 when David Sackett, a physician, very clearly articulated evidence-based medicine. And as he thought about it, it was a way to develop a treatment protocol for the individual patient. And it was built on 3 criterion. What's the best evidence for how to treat this patient? What does my own experience teach me about what have I learned that I can use? And then what are the informed preferences and values of the patient? So the real focus was on treating the individual patient. There was a lot of pushback to that. Some physicians saw that as a way to just further constrain their autonomy, whereas others said this is a really good corrective for what we were calling cookbook medicine. But 2 important principles emerged from that. We have to use the best available evidence, and we have to involve the patient in decision making. Evidence-based practice, on the other hand, is more about solving a clinical issue or clinical problem that's being experienced by nurses or members of the interprofessional team. It uses a structured approach to really hone in on what's the real problem we're trying to solve, what's the evidence, how strong is it, what's the quality of that evidence, and then synthesizing it into a solution that can be translated into practice. By its very nature, it's mostly interprofessional, involving a team working on a problem. At SSM Health, we use the Johns Hopkins model for evidence-based practice.
That was a great explanation. Thank you. And thank you for kind of taking us through the history, too, of thinking about the development of evidence-based medicine and evidence-based practice. And I even think about my own career, Chris, and my journey through, my different programs of study and degrees, and how much more important evidence-based practice has become, and how much more grounded each of our academia histories have in evidence-based practice, and really turning to the literature, understanding what the quality of the evidence is, and then thinking about what are those things that we should be implementing in our daily practice in order to improve outcomes. So with that said, talk to me a little bit more about why evidence-based practice is so important to nursing. Like I pointed out, it's being embedded in all of our curriculum today, even in our bachelor's level programs. Everyone has a course in evidence-based practice and assessing the literature. And evidence-based practice is really woven throughout all of our curriculum. So how do we take that and really apply it to practice, and why is it so important in the practice setting?
I think that evidence-based practice is so important for nurses because we practice at the sharp end of the system. We are in the best opportunity to see where things could be better, where practice could be improved, where it's drifted, and to have the toolkit that gives us what we need to figure out what's going to make things better for our patient is very essential. I also think because of our 24/7 presence at the point of care, we're in the best position to ask the rest of the care team, what evidence is guiding you? And really sort of coalescing the whole team around the importance of evidence and not just following what's habitual, what we learned in school, and really sticking to what's the best contemporary evidence.
So sometimes when we talk about evidence-based practice, a word that has a negative connotation comes up, and that word is standardization. And from my perspective, the reason that word has a negative connotation sometimes is that we all were trained, regardless of what clinical discipline we are, to be autonomous in our practice and to be critical thinking decision makers, because every patient, every encounter is unique. And so there sometimes feels like there can be some polarization between this idea of autonomy and doing what's best and right for the patient who's in front of you, while also thinking about standardization. So will you talk to me a little bit about standardization and autonomy and how they go together or maybe don't go together?
Yeah, that's a really great question. It's really true that some practitioners do resist standardization, whether it's using an evidence-based protocol, standardized equipment and supplies across the system, or even an evidence-based script for giving key messages to our patient. And, it may be just resistance to change, but it's often this feeling that it's shutting down my professional autonomy. I went to school, I have a license, I don't need to be guided this strictly.
Right. This is where the term cookbook medicine came into play, right?
Absolutely. But I think when we have standardized processes, it gives us visibility and clarity to what we're doing so that we can recognize when we're drifting, when we're not getting the best outcomes that we want, when we're not delivering value to our patients. But I think there are two things that messages I'd like to give you is I think practitioners need to think about standardization as a benefit to them because it takes care of those routine things that can be guided by evidence and frees them to solve those very individual, very unique problems that their patients have. It lets people practice at the top of the license one-on-one with their patients. The other thing that I think is important is people think that standardization shuts down on innovation, that it bounds our creativity because we have to do it the way it's designed. And I actually think that standardization is the springboard to innovation. Okay, and the reason I think about that is, what's an innovation? It could be small, or it could be something very dramatic across the entire enterprise. But the bottom line is, it's something that adds new value for our stakeholders. And so whether it's our colleagues, our patients and families, the organization, there's this new value that's added. But how do you recognize and measure new value if you don't have a baseline metric against which to measure it? So I think get your baseline, try some tests of change, innovate, reach for a new baseline, small tests of change, innovate. So that's why I think it's a springboard and completely consistent with our operating model.
Oh, that is such a great point and such great explanation. So share with me a little bit, Chris, about some examples of standardization in our organization and other organizations that are really making real-world impact in clinical outcomes for our patients and also for our clinicians.
So I think a couple of examples that come immediately to mind for me are the reduction of surgical site infections. SSM, through the wonderful work of our infection prevention team and our infectious disease program, has adopted a bundle of practices that have been demonstrated to reduce the incidence of surgical site infections. We know that if we treat the skin with antimicrobial soap, do the correct surgical prep, manage blood sugar levels and temperature during surgery, pre-op antibiotics according to the correct schedule, even things like enhanced recovery after surgery, demonstrating over and over that these reduce surgical site infections, and we certainly see it in our own data. The other thing I'd really like to point out is the reduction of urinary catheter-associated infections, or CAUTIs. Several years ago, nursing did an evidence-based practice project at SSM, and we used that evidence to develop a nurse-driven removal protocol to make crystal clear the criteria for having a urinary catheter in place, and nurses would remove it when it's no longer required. But then we extended that with a urinary retention protocol and bundle that into a set of practices and embedded it into our electronic health record for decision support. I think when we look at our own internal goals for CAUTI, as well as external goals from NISN, which is our comparative database, we're performing at an outstanding level in terms of reducing CAUTI, and it's all because of evidence-based practice.
So, Chris, you've really been instrumental, in my opinion, in raising the bar at SSM Health, and especially in our nursing profession, but in our physician colleagues as well. Everyone looks to you in this organization as an expert in this space, and you've been thinking about too. How do we grow evidence-based practice? How do we embed this every day in our work, in our thinking, and how are we incredibly intentional about this? And as a result of your leadership in this space, you have been working on our evidence-based practice fellowship program. So I'd love for you to talk a little bit about what that is and how it's transforming the way we think and use evidence.
So the Evidence-Based Practice Fellowship is in its third year, and we're currently recruiting members for a fourth cohort. As I mentioned, we use the Johns Hopkins evidence-based model for nurses and members of the healthcare professions. It's a year-long program with 6 months of didactic content, so classroom learning, and then 6 months of actually figuring out how to translate what we learned into practice. We're building individual competency for evidence-based practice by educating these fellows, but more importantly, we're building organizational capacity for evidence-based practice, for understanding what it is, being comfortable with it, and seeing it as our change model, our value model. Two projects that I'm really most excited about that I wanted to talk about is one that is designed to treat patients who are experiencing alcohol withdrawal. And as you know, there is significant morbidity and even mortality associated with that condition. And we recognized that we were not following the most current evidence, and we certainly weren't achieving the outcomes that we wanted to, mostly over-sedating, under-sedating patients, and not giving them the valued care that they deserve. So one of our projects was a nurse-pharmacist collaboration.
Yes,
so I loved that.
Interdisciplinary team.
Absolutely. And they did an extensive review of the evidence for the pharmacological management of alcohol withdrawal, but more importantly, additional assessment protocols. So we'd really have a better understanding of where the patient is. So we now have an order set, multiple assessment protocols, and then treatment guidelines that are absolutely aligned with the best evidence. And we've seen great practitioner uptake, not only on the nursing side, because the guidelines are easier to follow, but the physicians really appreciate the better care. The second project I want to talk to you about, and this is one that I was actually a mentor for, has to do with the concept of nurse worry. So the fellow brought the project to us that in her own experiential evidence, when she had a certain degree of worry about a patient, they often, within the next 24 hours, would experience physiological decline. And we pass that off as, well, that's just your nursing gut, it's your sixth sense, it's whatever it is. But she was convinced that there was something that we could quantify or better understand. So she did an evidence-based practice project and found one high-quality study that explored the concept of nurse worry with a scoring system. But you can't change practice with one study, So she decided to do a replication study, got IRB approval, conducted the study, and we recently concluded the analysis. And not only did she replicate their study, the sensitivity and specificity results of her study were nearly identical to the original study. It's incredible, and I can't wait to help her translate this. But if you think about it, we have tools in Epic that, tell us this patient might deteriorate. But if you could enhance that with a nurse worry factor, and then help physicians, nurses, other members of the team to understand this is real. You can increase nurses' willingness to activate a rapid response system, be more comfortable talking to the providers about, I'm worried about this patient, and it's at a medium level, it's at a high level. And I think it has the opportunity to enhance our ability to decrease failure to rescue.
Yeah, I was going to say, talk about early recognition. So what a great topic. I'm so glad that you shared this story because this points out a couple of things. So the first thing is that clinical inquiry, that question. There's questions that when we're practicing, we think, why are we doing this? Or what about this? And so this all started really with the question that one of our clinical nurses had, then going to the evidence, looking for evidence, then recognizing there's not strong evidence, right, and really turning this then into a nurse-led research study. And so talk about showing the whole value proposition of understanding evidence and why we make some of the decisions. And then I just think about the potentials of this question. You're right. All nurses have this sixth sense or this intuition. Sometimes translating that to another practitioner, clinician, provider, it's difficult. And so being able to quantify that in a measurable and meaningful, repeatable, reliable way really has the potential of changing care.
Absolutely.
So, Chris, we talked about our evidence-based practice fellowship program, and we're seeing these programs kind of emerge across the U.S. in different healthcare systems. Why is the evidence-based practice fellowship program important? And what is the value proposition to the individual clinician who is participating in the program?
That's a really good question, Amy. The fellowship program is designed to, as I said, build that individual competency for evidence-based practice. But as that individual completes their program and goes back to their home department, they can become an ambassador for evidence-based practice and sort of be that nucleus for that organizational capacity for evidence-based practice. The other thing I'd really like to mention is that our program has been externally reviewed and has been found to be graduate level education for evidence-based practice. And that allows the individual who has completed the program to sit for the EBP certification exam. It's fairly new. There are a very small number of individuals across the country who have this designation, but it is a wonderful opportunity to learn and to share the principles of evidence-based practice across the enterprise.
Oh, that's great. And so it really designates the clinician then as expert, and maybe most importantly, mentor and teacher to others. So it expands that organizational capacity that you were discussing earlier.
So if someone on a unit that, say, you have completed the fellowship program and are certified, they have an idea, they'll know to go to you as the first step to say, is there anything in my idea? Help me figure this out. Help me write a PICO question or a research question. And so it's that nucleus of capacity for the entire organization.
So as you think about evidence-based practice and you think about where you want to see us go as an organization, where you want to see the nursing profession go with evidence-based practice, what's your hope? What's your dream? What's your magic wand moment?
So I think we need to think about evidence-based practice as a correlate of our operating model. When I think about the operating model and what it does is it embeds operational excellence into our day-to-day work, into the DNA of the organization. And so my dream, my wish list would be that we think about it the same way, that evidence-based practice embeds clinical curiosity, that questioning attitude. I like to think of it as a restless practice, which is the opposite of a complacent practice, that you're always restless for what more can I do, what more can I learn, what next question needs to be asked. And so that's my hope for evidence-based practice at SSM, that we become a restless nursing organization that is always questing for something a little better for our patients and for our organizations.
That's the true definition of a growth mindset and a learning organization.
Yeah.
Meaning that it's a constant journey. The more we learn, the more we see, the more opportunity to get better and better. So I love that. So Chris, as you think about, I always like to leave folks with a call to action. As you think about what that call to action is for our nurses, for our other interdisciplinary colleagues, for our physicians, and for the greater nursing profession, what is that at the individual level and the collective level?
So at the individual level, just instilling that sense of restlessness, of questioning, clinical curiosity. Why did that happen? I've seen that before. Is this something I need to, think more about and embed into my own practice? At the organizational level, extend the fellowship to more members of the interprofessional team. My absolute wish would be get a lot more titled leaders into the fellowship program. I think we're getting incrementally better at embedding evidence into our clinical practice, but we have vast opportunities for embedding it into our operational practice. And so I think that's important. I think it's important that we We have a really good solid process for uptake of these initiatives. I see too many that we finish them and you report off to the unit or the sponsor, and we're really not good at spreading the innovation, not only within the organization, but outside the organization as well. I'd like to be able to tell SSM's story about how we are innovative, we're creative, and we're making patient care better and of higher value because of the way we're using evidence-based practice.
Yes, that's a great example of how we create these pockets of clinical excellence and we fail to scale and spread. And in order to do that, that means we have to publish.
Absolutely.
Right? We have to tell our story.
The 3 Ps: publish, present, podium presentation.
There's one other question I want to ask you about before we leave today, and that's about the concept of psychological safety. So what you've left us with the call to action is really about people being curious, people being restless, learning to be a learning organization, learning as individuals to have a growth mindset over a fixed mindset. And in order to do that, we have to have psychological safety. And I know this is a topic that you're passionate about. And so I'd love just to hear you talk a little bit about how you think psychological safety plays into proliferating evidence-based practice across the organization.
So I think there's a couple of places that it really plays into. The first is that individual practitioner who's got a question but thinks this might be a silly idea. I'm not going to raise it. So creating spaces for people to get their ideas out, whether they're a wild idea, whether they're a challenging idea, but just to create the space for that to happen. The other thing that really is related to psychological safety is that not every project will be a grand slam. Projects will fail, and what we need to understand is that's a good thing, because if we're not failing, we're not learning. And but the key is fail fast, learn fast, and then what's the next step to advance this idea? So I think psychological safety has everything to do with our being willing as individuals and as an organization to take risks and be willing to fail and pick ourselves up when the failure happens and celebrate it.
Yes, thank you for sharing that. And, I think we forget sometimes that we all learn more from our failures, because it really is about learning through the failure, pivoting, iterating, and keeping moving to get to the outcome that you desire.
Absolutely.
So, Chris, thank you for your leadership, and thank you for being here to talk about this really important topic today. I'm excited about where we're headed in SSM Health around evidence-based practice, and I'm excited about where we're headed as a nursing profession in really grounding evidence in every single thing we do and in all of our decisions.
Thank you, Amy, for the opportunity to tell our story about evidence-based practice.
Absolutely. So every nurse, every leader has a role in making sure care is guided by what works best. Evidence-based practice is how we build trust, deliver value, and shape the future of nursing. So I'll leave you all with a call to action today to get involved, to turn to the literature, to get curious, as Chris said, to be restless, and to ask those questions. Thank you so much for joining me on this episode of Healthcare Disrupted. We want to hear your voice, so dive into the conversation with us, challenge us, and help us disrupt healthcare for the better. Like this episode, subscribe now, and wherever you get your podcast, follow us on this journey.